So I'll keep it brief and only a few slides for head and neck cancer and 10 choosing wisely, starting from the first one. Tobacco cessation, I think so. I don't need to talk about it. This needs to be done. These are some simple interventions. We miss it, and then we realize a good number of patients, in spite of almost all squamous cell carcinoma of head and neck cancer being tobacco related, ends up having tobacco, because the time and this to be spent to see that they don't take tobacco subsequently, it doesn't happen. And but without doubt, there's a whole lot of proof that one needs to have a tobacco cessation in patients in head and neck cancer receiving getting treatment for head and neck cancer. Yeah, correct. Sarvani told she'll be around. So proton therapy should not be considered for routine use in head and neck cancer in majority of the patient. I've been very careful with all the words when I said this. So this is a systematic analysis for all data which is available for proton till now, and what we have known that proton compared to other technologies, whatever is available, doesn't look like, as Dr. Jan Tanak taught us in the morning, and otherwise that it adds life or improves quality of life. That doesn't happen. But we do know there are certain technological advances. Let's see if it really turns out to be or not. Until that time, maybe proton has a role, but not for routine care. Third one, robotic surgery. Pramesh is here, Sarita is here. So robotic surgery should not be used routinely in head and neck cancer. And you do have now 2 trials, and there was a merit, and there was a huge merit for early lesions, especially when we had Orator trial. But you do have Orator 2 now. And Orator 2 does lead to, and especially in the context of cervical cancer trial for robotic, one needs to be a bit watchful about it. And as far as the Orator 2 trial data is concerned, you do have certain side effects, which are all complication, is more for surgery, but there are certain of them which is more for radiotherapy, depending upon which way you see. But what was the primary endpoint? Primary endpoint was this. People try to see that, can we put all the subsites and then see that quality of life data? What is the MD, ADI, this for dysphagia, they try to see in the 2 arms. Doesn't look like, whichever you say, the curve of robotic is above the radiotherapy. It remains below it. So it does raise the concern that at this moment, routine use of robotic for head and neck cancer, and this was fairly chosen patient where they had done this randomized trial, it was not better. So this is for robotic, and as far as head and neck cancer is concerned, and this is my take on this. Next is okay. This is for Dr. Banavli sir is not there, so I'm safe today. So metronomic chemotherapy in adjuvant setting, specifically the drugs I'm mentioning, the methotrexate, celecoxib. In adjuvant setting, the post-treatment, that is post-chemoradiation or post-surgery and post-chemoradiation or radiation, should not be used routinely in head and neck cancer. I'm saying it randomly? No, I'm not saying it randomly. We have 2 randomized trials, and both done at our place. One was done in the patient with a head and neck cancer where they had a recurrence, and after that, again, the surgery was done. And after surgery, they were randomized for, because they were not fit for radiotherapy, so they were randomized for metronomic chemotherapy, and they were a second arm randomized for observation. And what we can find that anyone can see that the curve for observation is above, and it has remained above, whichever way we have looked at. We waited, we put this in public domain after waiting for it. Are we missing something? We waited for a year or 2 to see, is the curve changes? Is there something different happening? No, it remains the same. And for that in setting, this is not the only randomized trial. So it was like when we put it there in the public domain, we're looking for, because there was another randomized trial which was going on, what comes out to be it. This is another one which we presented in ASCO this year. This was upfront patient who has gotten complete remission after chemoradiation. And then after chemoradiation, patient has gone in complete remission, then randomized to metronomic chemotherapy versus observation. And this was the schema. A relatively big study, but it had interim analysis, and what we can see it here. Again, the curve for metronomic chemotherapy, again, I repeat, is metronomic chemotherapy, adjuvant setting, and the drugs are, all metronomic is not the same. Don't get me wrong. These are different combinations, different drugs. So it is methotrexate and celecoxib. There is some issue there. And that's the reason I told in head and neck DMG meeting, I stick my neck out. There are 2 more study which is got completed. Data analysis is going on, one by Dr. Prathamesh and other by Dr. Pankaj, and say, I think so, your results are not going to be any different. So there is a concern regarding it, use in the clinic. And why I put it here, because there is a whole lot of use, because this is easy to use drug. People think anyone can give it. Anywhere the people have a high risk feature, they are worried about it. And as a clinician, we do get worried about it. And once you tell your patients, oh, आपके पास 10 node वापस आया है, you have a 10 nodes, extra capsular spread is there, you can't do anything, and then say, give something. But then we say, okay, this is easy to give. I used to give it. We have stopped giving it, subsequent to these trials. Next one, cetuximab. See, Amol, I'm on your side. Cetuximab should not be considered if patient is fit for cisplatin in patient receiving chemoradiation. There is a randomized trial for cetuximab in patient fit for cisplatin, comparing cisplatin plus radiotherapy versus radiotherapy. There is a survival advantage. You do have a cisplatin trial, cisplatin plus radiotherapy versus radiation, and there is a survival improvement. Yes, you do have a randomized trial now, and people do think that cisplatin is similar. It had a category 1 recommendation till recently. Now it has started changing. The category has been changed in NCCN also, and this was the study which suggested that in the patients who, if you compare cisplatin versus cetuximab, the overall survival in patient receiving cetuximab is inferior as compared to the patient receiving cisplatin. So routine use of cisplatin, cetuximab replacing cisplatin in head and neck cancer where you're using radiotherapy is not a good idea. Next one is de-escalation. De-escalation in head and neck cancer should not be done routinely. We know, we have heard a lot about it. HPV positive patient outcome is good. Absolutely no doubt about it. HPV positive patient not having a tobacco habit, outcome is good. Multiple data. You have multiple data from India. Our own data, which we published from here. From India, from Tata, you have at least 2 data. One from you get a Dr. Vanita and Dr. Vijay, another from Dr. Vedant, suggesting that it is there. But is it the time to de-escalate? Yes, people did try it, and this is what they did. It called de-escalate. They compared cetuximab versus cisplatin in HPV positive patients. And who thought of HPV positive patients? They said, hey, RT may be good enough, but that's not true. If you have a HPV positive patient in a head and neck cancer, and if you're using cetuximab plus radiotherapy, it is inferior as compared to cisplatin plus radiotherapy. There are a whole lot of trials where de-escalation is being tried. NSAT followed by only surgery, NSAT followed by lower dose of radiotherapy, CTRT with lower dose of radiotherapy, lesser chemotherapy. Be careful. The moment you do a bigger study, sometimes you get surprised. And the surprise is the difference is almost 8-9% in the survival. If that remains true, everyone can worry that what kind of benefit you are getting with cetuximab, because absolute benefit cisplatin is around 8 to 9%. But again, that's a different trial and different comparison, but giving a hint that not a good idea to de-escalate at this moment. Cisplatin ineligible patient. So cisplatin ineligible patient needs to be treated with chemoradiation with addition of non-cisplatin based chemotherapy. Till recently, there was no randomized trial in cisplatin ineligible patient. We used to extrapolate the data from 5-FU carboplatin in patients who were cisplatin eligible. They were randomized radiotherapy plus 5-FU carboplatin versus radiotherapy, and it improved survival. Cetuximab till now never done a trial in cisplatin ineligible patient in a randomized setting, and the data was cetuximab plus radiotherapy versus radiotherapy and improvement in survival. Yes, there is a data for immunotherapy in cisplatin ineligible patient. That's a negative trial. This is the only randomized trial, and this trial was presented as an oral presentation for docetaxel, and docetaxel was 15 milligram per meter square weekly for 6 weeks for these these patients, and it was docetaxel with radiotherapy versus radiotherapy in cisplatin ineligible patient in this study. And what we can see that I'm showing only part of this data. That is overall survival. The DFS and OS both improved if you do it. What it means that in these cisplatin ineligible patients, some form of chemotherapy is required. I'm not saying docetaxel is the only drug. That's why I didn't put it docetaxel. Think if you want to give 5-FU carboplatin, please go ahead, give it, but it has not been tried in cisplatin ineligible patients. Cetuximab, NCCN does recommend in cisplatin ineligible patient that one can give it, but again, that trial has not happened. Immunotherapy, one negative trial, other trials are on. Here, you do have a positive trial. If you want, you can give it. Triple metalonic chemotherapy with low-dose nivolumab needs to be considered in patients requiring immunotherapy in head and neck cancer. Based on, it is not in journal, so I'm waiting for that. That's why I put it, needs to be considered. I have not said this should be used. Amol is smiling. Amol, you can say, yes, it can be. I'll be happy about it. But, yeah, so I'll wait till it comes in journal, like to see the editorial. So good to hear that. This is always nice to hear. If your data in public domain starts making difference, and this is what I know definitely I do personally and my group, we always talk to our colleague whenever we have put data in public domain, what has been their experience? Either it is metalonic chemotherapy, triple metalonic chemotherapy, or it has been weekly, 3 weekly cisplatin, or by JFJC data, which we show, hey, what do you feel when you're using 20 patients, 30 patients, 40 patients? It is different. I totally agree. It is a different drug combination. I say people using 10 patients, you don't require more than that to convince you that this drug and combination works differently. Because 6 out of 10 patient response usually doesn't happen in head and neck cancer. Not compared to breast cancer. Don't compare with breast cancer group who are sitting there. There, most of the patient response. Head and neck cancer, if you have a 2 or 3 patients responding to chemotherapy, you are more than happy. So, the moment you have a 6 out of 10 responding, it is LMIC as per Amol is concerned, head and neck. Huh? So, this was a randomized trial. We have seen many more than once today, which compared triple metalonic chemotherapy versus triple metalonic chemotherapy plus immunotherapy, and showed that it improves PFS and OS both if given these patients, and it does decrease the cost. Amol, totally agree with you. And head and neck is another area where NGS or liquid biopsy in squamous cell carcinoma of head and neck cancer, whichever way you say. Now there is a whole lot of data from India that you don't get any targetable lesion, and we keep thinking we'll get something someday, and we keep hoping. Some data with MSI is high is there, but let's see. We are waiting for the data to mature. HPV testing should be avoided in non-oropharyngeal head and neck cancer patient. Oropharyngeal cancer patient, very important for prognostication, not for treatment. Prognostication, no doubt about it. Whichever data you look, HPV positive patient, especially non-tobacco, they are different. But all other sites, something happens. You don't get any the thing out there. Somehow nothing works. Last one, our data. So I thought I'll put it in borderline resectable patient. Don't give palliative treatment. If you do this approach, give NSAT. 25% patient you will give long-term survival. 50% or 40 to 50% will get resected, and half of them will be long-term survival. So let them get the knife, as what Amol said. Get them knife, let them remove the tumor. Thank you so much.